We are meeting again on 16th of December, live on social media and on CMAAO platform. And we are discussing a very, very important topic. Everybody is facing a sudden cardiac death or heart attack. So we are discussing on sudden cardiac death risk evaluation. And to discuss about this, we have Dr. Mahesh Shah with us. He's a leading cardiologist in India. He's a senior and eminent aggressive intervention cardiologist active in complex of high risk multi-vessel coronary, renal, and angioplasty and stenting. He's practicing in MK Heart Care at Mumbai and affiliated to Hinduja, Breach Candy, Nanavati, and all other hospitals. He's graduated from Shri Chitra Institute and developed Department of Cardiology at BHEL Bhopal. He's a certified hypertension specialist by American Heart Association. He has multiple research and publications in his name. Sir, over to you.
Thank you. Thank you, Simao, and thank you, Mr. Saurabh, for today's beautiful opportunity to talk on sudden cardiac death. Well, friends, predicting the risk in sudden cardiac death is very important. What is sudden cardiac death? Sudden cardiac death is any unexpected death from a cardiac cause within a short period of time, that is usually less than an hour, and sometimes it's in seconds and minutes from the onset of symptoms. And many times this would happen unwitnessed. So for research and technical purposes, it's defined as if the person was seen alive last 24 hours before and if he is found dead, it is defined as sudden cardiac death. All sudden cardiac death patients are not really dead, because some of them, they self-resuscitate and they come out spontaneously. Some of them, they revive based on the bystander-initiated CPR. Bystander-initiated CPR is an extremely important skill which should be imparted to large number of population. And I think your organization and Saurabh can probably take a lead, and we can save large number of meaningful lives by imparting CPR. So maybe we can discuss that someday. And of all the presentations, all types of presentation of cardiovascular disease, sudden cardiac death is the most challenging, most feared, strikes without warning. It comes like a bolt from the sky, and it occurs in large number of previously apparently healthy individuals. We are flooded with this kind of news because as soon as this happens in some important person, some doctor, film personality, politician, sportsman, and it becomes a big news and people start getting scared of cardiovascular disease, and we get a flood of consultations once those kind of news are there. So to put those things in perspective, half of all cardiac deaths, irrespective of what is the cause of cardiac pathology, whether it is coronary artery disease, cardiomyopathy, valvular heart disease, say what, half of the cardiac deaths would be sudden, because once the heart has been deranged structurally or functionally, arrhythmias, particularly tachyarrhythmias, can arise, and half of the mechanisms of cardiac deaths are sudden cardiac deaths or arrhythmic deaths. And half of the sudden cardiac deaths, they present as a first cardiac event. Those patients will not have any prior suspicion of cardiovascular disease. So that is fairly scary. And among all the deaths, almost 15% of the deaths worldwide are because of sudden cardiac death. And as we know, cardiovascular disease is the leading most cause of death across the world, whether it is developed countries or developing countries. And half of them are sudden. So you can imagine the magnitude of the problem which we are facing. And annual incidence is something like 30 to 125 per 100,000 person years. That's not very low. And when you translate into the absolute numbers, it's 6 to 9 million deaths every year, out of which almost 5 lakhs are in US, 5 lakhs are in Europe. A significant number of them could be predictable, and if they are predictable, it can be prevented. Though today's talk is only on risk stratification, but just a slide on what we can do if we find a very high-risk person who has a sudden cardiac death or who already had sudden cardiac death, and now we need to do a secondary prevention. So obviously treat the underlying disease, whatever is the cause of the disease, that is the best treatment. And if that disease treatment is not possible or disease has damaged the heart to a significant extent, then of course you add lifestyle and anti-arrhythmic drugs. We know there are a lot of limitations of anti-arrhythmic drugs in terms of safety, efficacy, side effect, etc. So we have a universal device known as implantable cardioverter defibrillator. It's a pacemaker kind of device which you implant below the skin, lead goes into the heart, keeps on monitoring every heartbeat, and as soon as deadly rhythm arises, it detects it within seconds and gives an electrical shock to the heart to restart the heart to a normal rhythm. Obviously, if you can find out certain focal areas from which these electrical impulses are arising, you can ablate those things with a radio frequency ablation. It's an invasive procedure wherein you take electrodes into the heart, find out the areas which are defective, and ablate those areas with the hope that recurrent ventricular tachycardia, fibrillation, and sudden cardiac death incidence would come down. And in selected group of patients, you can use a left cardiac sympathetic denervation. We know autonomic nervous system, sympathetic and parasympathetic system has a very important role to play in cardiac rhythm. And in selected group of patients like certain types of channelopathies, long QT syndrome, arrhythmic storm, etc., you can use left cardiac sympathetic denervation. It's a surgical procedure. So what is the size of the problem? As I told you, this is just the US data. And among all the deaths, sudden cardiac deaths, almost 3 lakh deaths are there. Compare it with stroke, it just reaches half the mark. Lung cancer, accident, breast cancer, AIDS, and even fires have been compared. So we are all prepared with fires. We prepare, we predict fires, we take a lot of preventive measures, and when we have an emergency response system for fires. But for sudden cardiac death, unfortunately, that prediction so far has been difficult, and the prevention also has been difficult. But just imagine if for fire prevention, if we spend so much of time, effort, and money, how much we should be doing for sudden cardiac death. And despite major improvements in medical and research community in past decades, the prognosis in patients who already get an out of hospital sudden cardiac arrest is very grim. On an average, maybe 5% of the patients survive, but the best report is something like 13%. Of course, if the sudden cardiac arrest occurs inside the hospital, or still better, inside the ICU or operation theater, then almost 30% of patients would survive because they get immediate cardiac care. But out of hospital cardiac arrest, particularly if there is a no bystander initiated CPR, survival rate is hardly 5%. And with every minute of delay in initiating CPR, your survival rate drops by a relative 10%. So that is the importance of the sudden cardiac death and CPR. So why do we need to predict? Because this is a very sudden disease. There is no time to treat once it occurs, and once it occurs, it's very rapidly fatal. As I told, the survival rate decreases by 10% with every minute of delay in initiating CPR. It is common. We have seen large number of deaths are because of this mechanism. It is preventable if predicted. And now a lot of research and data is coming forward, wherein it is becoming more and more predictable. Of course, we have a long way to go to have an ideal prediction system. But today we are going to discuss what all things we can do. With the massive advancement in understanding of the mechanisms, both cellular as well as molecular mechanisms of chronic cardiac diseases, our knowledge is getting better and better. And the therapy, once the disease occurs, once you have a coronary artery disease, cardiomyopathy, the therapy has almost reached its peak. If you see the cardiovascular death rate in US, over the decades it had dropped down, but last few years you can see there is an uptick, because the therapy, cardiovascular therapy, once the disease has manifest and it has occurred, you treat it, we have reached the limit. The only way we can improve the outcome of treatment of diseases is by implementing the guidelines, because we know a large number of patients with hypertension, diabetes, dyslipidemia are not being treated as per the guidelines. So compliance with the guideline, implementation of the guideline is the one way by which we can improve cardiovascular health. But still more important, there is a huge number of primary prevention patients who do not have existing cardiovascular disease. And this group of patients, if we can find out those who are at a higher risk, because preventive strategies like ICD, if you put ICD to each and every patient in the world, sudden cardiac death probably will disappear. But at what cost? And that does not come without any consequences like side effects, etc. Every 5 years, you might have to replace the ICD device. So you need to find out a focused group of people who have a very high risk of sudden cardiac death, and thereby the cost, risk, and consequences are justified in those group of patients, because you can make a meaningful difference. Now, the classical way in which we identify high risk people are the people with uh, LV ejection fraction of less than 35%. Ejection fraction is so far the best predictor. So 35% ejection fraction, less than 35%, the incidence group of sudden incidence is something around 18% over here, you can see. And if the patient already had one episode of previous cardiac arrest, the incidence goes up to 25%. And if the patient had an he had an infarction, low ejection fraction, as well as history of ventricular tachycardia, the incidence goes high up to 30%. But what about this three group of patients in absolute number in the population? The number of sudden cardiac deaths is not that big. As compared to that, if you take general population, the incidence might be just 2.5%. But in absolute numbers, because that's a very big base effect, the general population is far bigger than this high-risk populations. The number of sudden cardiac deaths here is absolute number is much higher, and that could be a potential target wherein we can improve the overall survival in these patients. And if you take a patient with high coronary risk profile, the incidence rate is something like 3%, but again, they are a very large group of patients. So that is the importance of filtering out from a large group of patients those who are at high risk, and that's relatively a difficult job to do. Age is another important variable in terms of sudden cardiac death. The incidence of sudden cardiac death varies, and even the causes of sudden cardiac death varies with age. Largely, there is a predominance of monogenic and oligogenic diseases in the young patients below the age of 35, like primarily electrical diseases, long QT syndrome, Brugada syndrome, variety of cardiomyopathies like dilated and hypertrophic cardiomyopathy, myocarditis. Above the age of 35, the coronary artery disease starts taking up the front stage, and acute coronary syndrome and chronic coronary syndrome would contribute to larger and larger. And once a patient becomes elderly, say above 60, the chronic structural heart disease, because all the traumas of the life on the heart leads to a lot of scars, and scars, as we know, would ultimately increase the risk of electrical heterogeneity in the heart and increase the sudden cardiac death risk. In people above the age of 50 years, in people below the age of 50 years, it's estimated that 70% of sudden cardiac death cases are potentially because of inherited causes. So genetic evaluation in those group of patients, focusing genetic evaluation in those group of patients is likely to yield much better results. Here you can see the incidence of sudden cardiac death as per various age groups. In very young age, there is a higher incidence, probably because of a lot of congenital disorders, channelopathies, etc. It pulls out around in second decade of life, and then every decade of life it keeps on rising. The graph looks linear, but see, the y-axis is the scale is logarithmic. So from incidence from say something like 8 to 10 per 100 per 10,000 patients, it goes to more than 1,500 per 100,000 patients. So that is something which needs to be kept in mind. Now, what are the mechanisms? How exactly the heart stops? Large number of patients, they have an electrical abnormality, that is either ventricular tachycardia or fibrillation in 75 to 80% of patients. Bradyarrhythmias, very slow heart rate or cardiac asystole accounts for 15 to 20% of patients. And electromechanical dissociation, wherein heart gets ruptured or valve starts suddenly severely leaking in such a great hemodynamic dynamic extent that heart cannot effectively pump blood and it comes to an end. So these are the mechanisms, and ventricular tachycardia is the main focus for detection. And what are the underlying etiopathologies or causes of those heart conditions? Of course, coronary artery disease is the most common in majority of countries. Japan is an exception where it is only 25 to 50%. Cardiomyopathies is the second largest cause, which could be hypertrophic cardiomyopathy, dilated or non-ischemic cardiomyopathy, arrhythmogenic right ventricular dysplasia. They all combined fully account for 15% in Western countries. Japan, the rates are much higher. And inherited arrhythmias, majority of them are channelopathies. The electrical conduction channels of the myocardial cells are defective. Long QT syndrome, Brugada syndrome, all those combined are responsible for 2% in Western countries, higher in Japan. And valvular heart disease and other miscellaneous disease take up the rest of the space. Left ventricular ejection fraction so far is the strongest predictor we have, and the guidelines for ICD implants largely focus on left ventricular ejection fraction. And uh, but there is a limitation to ejection fraction. Like as a in coronary artery disease, low EF is a very good predictor. But in dilated cardiomyopathy, the second commonest cause of sudden cardiac death, it's not a great predictor. So indication for ICD in ischemic cardiomyopathy, it's class 1 indication. But when it goes to dilated cardiomyopathy or non-ischemic cardiomyopathy, it becomes class 2 indication. And practically, if you see, only 1/3 of sudden cardiac death victims had lower ejection fraction. So 2/3, if you just use only this criteria, 2/3 of the patients you are going to miss from the net, and you will not be giving them appropriate preventive therapy. So we need to find out some more parameters. So if one parameter is not effective and other parameters are not even close to ejection fraction in terms of their predictive power, what do? You combine multiple parameters together and find out some kind of risk scores. Here you can see in people with ejection fraction below 30%, the uh, incidence prevalence is very high as compared to people who are above 50. Almost 5 times the difference between above 50 versus below 30 is found. And again, functional class of patient, NYHA class 2 and 3 patients, sudden cardiac death is almost 60%. But once you reach NYHA class 4, where ventricle is irreversibly and very badly damaged, the progressive heart failure takes up the center stage, primarily because they have reached a stage where progressive heart failure becomes more and more prevalent and sudden cardiac death relatively comes down. So it is in this group of patients you can focus your cardiomyopathies, etc. Now, what about the electrical parameters or manifestation? Ventricular premature beats, we know that they are harbinger of ventricular tachycardia, fibrillation, and sudden cardiac death, but they are very common. If the patient had a normal ejection fraction, no LV dysfunction, the VPCs, presence of VPCs, whether they are none or 10 per hour or more than 10 per hour, they do not differentiate much in terms of survival. But once you have a low ejection fraction combined with higher prevalence of VPCs, and you can see it becomes a big differentiator. So that is the kind of multi-parameter that is the kind of multi-parameter evaluation which, when you combine together, that your risk prediction model becomes stronger and stronger and your yields are better. Electrocardiogram is something which is ubiquitously available, and we look for few parameters, maybe half a dozen parameters. What are the parameters we look for? We look for heart rate, QRS duration, fragmentation of QRS, JTC interval, partial ECG parameters or global electrical heterogeneity, QT prolongation, T inversion, but they are just half a dozen parameters. When you a single parameter is not that differentiating or predicting power, but if you combine multiple parameters, people have shown that when you keep on adding a few parameters, the predictive power goes up. And there are certain early studies which have proven in field that these scores are important. So ECG is the electrical physiology of the heart. Now we focus on the structural aspects of the heart and multimodality imaging. Echocardiography, of course, we do it in practically every patient with any cardiovascular disorder, but it gives you certain limited information. In addition to that, if you want to risk stratify, you look for other parameters, the underlying myocardial substrates, the structural substrates which predispose to sudden cardiac death, like cardiac magnetic resonance. And in that, if you use late gadolinium enhancement, late LGE predicts, it shows you the myocardial scar. And overall, how much is the scar burden? Which are the regions which are affected by scar? What is the heterogeneity of all the scars? When you combine all of them together, you can get beautiful data which help you in risk prediction. The nuclear methods like single photon computed tomography or positron emission tomography, they help you in determining myocardial viability and sympathetic, parasympathetic innervation of heart as well as inflammation of heart. We know all these parameters are important in predicting myocardial arrhythmic events. CT scan tells you about the myocardial fat, and association of myocardial fat with reentrant circuits is already well established. And there are newer computer models which develop virtual hearts, which help you understand the complex electrophysiology and modeling of heart derived from all these parameters. But the beauty comes from AI. The deep learning, which is a subset of machine learning, can help diagnose early disease. We as humans can take care of 2, 3, 4, 5, maybe 7 parameters. But when the data is fed of thousands of patients, it can look into that seemingly simple ECG, and it can look into hundreds or even thousands of parameters and summarize the things which we cannot see. And based on that, the refinement of risk prediction can be much better. And this deep learning not only helps in interpreting the ECGs, but also interpreting the all multimodality imaging data. So when you combine both together, in near future, we are going to use these technologies more and more once we have a proof of concept. Now, you can use several biomarkers of sudden cardiac death. Which are those biomarkers which are associated to different pathophysiologic pathways? Biomarkers of inflammation like elevated C-reactive protein, interleukin-6, fibrinogen, and white blood cell count. The biomarkers of myocardial injury like high sensitivity troponin I, even in general population, when you select out people who have unexplained slightly higher HSCRP, and they are at a higher risk of CV disease as well as sudden cardiac death. The features of myocardial strain, like muscle is getting stretched, NT-proBNP gets secreted into the blood and you can detect it. Lipid parameters like circulating non-esterified fatty acid, remnant proteins, LDL can help you. Even simple hyperglycemia parameters like HbA1c, fasting post-lunch sugar refines the model for risk prediction. So this all add to what already we have in terms of electrical parameters, structural parameters, and then biochemical parameters. And genetics is the way to go. The genetic markers are many. The technology is getting refined. Whole genome analysis or whole exome analysis is becoming more and more easily available, as well as it is getting cheaper, so it is more accessible in majority of countries. And majority of genetic abnormalities are focused on ion channels, because ultimate mechanism in majority is the electrical abnormalities, ventricular tachycardia and fibrillation. So large genome-wide study was shown that there was no single nucleotide polymorphism which was associated with sudden cardiac death. So we are looking at polymorphic association, just like in coronary artery disease. You look at hundreds or thousands of genes, which might give you a small contribution to it, but more the number of genes, more the risk of sudden cardiac death. Except in South Africa, certain complex genes were found to be associated with sudden cardiac death. And in acute myocardial infarction, if you have SCN5A gene, then you have a higher chance of ventricular fibrillation. There is a lot more which needs to be researched into this, and we'll become wiser and wiser. But it's high time that we start thinking in those directions, so that when that technology comes, we are already well versed with it. And in a recent study, it was found that 20% of individuals had pathogenic or potentially pathogenic genetic variants associated with inherited cardiomyopathies or arrhythmia, despite having normal cardiac findings. They did not have any cardiac findings, but 20% of them have had those genes. How many of them are functionally really significant? It needs to be evaluated. Now, this slide tells you about the age, genetic composition, type of disease, and type of triggers. You can see the CPVT type of arrhythmias, exercise is a trigger, and this group of patients, they present within first or second decade of life, and they have a largely polymorphic ventricular tachycardia. Long QT syndrome, congenital long QT syndrome, again in early age and polymorphic ventricular tachycardia. Brugada in early adulthood, and again polymorphic ventricular tachycardia. Acute coronary syndrome starts at the age of 40, 50, again polymorphic ventricular tachycardia. While sarcoid, hypertrophic cardiomyopathy, dilated cardiomyopathy, and monomorphic ventricular tachycardia start getting precedence, and exercise, genetic composition, and time of day that controls the sympathetic, parasympathetic different tones, and that contribute to arrhythmia. So these all parameters can be kept in mind in evaluating the patient's risk. In patients, now we go to disease-specific predictions. So far, we have tried to look into in general population, but a specific disease-specific prediction in once a patient has, say, for example, coronary artery disease. Now, acute coronary syndrome, out of hospital cardiac arrest is quite common. Almost 13% of all infarction would present with out of hospital cardiac arrest. Before they reach the hospital, they will have a cardiac arrest, sudden cardiac death. They would either die or get resuscitated and reach the hospital. Ventricular tachycardia, sudden cardiac death is relatively high, and it persists for almost a month. If you can identify high-risk patients, and if the risk is only for 1 month, you can give them a wearable defibrillator. They just connect the defibrillator, walk around with it. They get cardiac arrest within few seconds. They get a shock and they get treated. So that is the power of prediction. And once the disease reaches into the chronic ischemic heart disease stage, there are many scars formed. Fibrosis happens as scars form. Scars are the morphologic or structural substrate, because scar will lead to electrical heterogeneity into the ventricle, and that will predispose the person to a ventricular tachycardia and fibrillation. So LV ejection fraction, ectopic burden, and residual ischemia, and quality, type, and heterogeneity of scars, these are few of the parameters which would predict sudden cardiac arrest in patients with chronic coronary artery disease. Now take the second largest underlying cause, that is cardiomyopathy. And among cardiomyopathy, dilated or non-dilated hypokinetic cardiomyopathy. The annual incidence of sudden cardiac death in overall this group of patients is 2 to 4%. And different non-invasive parameters such as non-sustained VT, T-wave alternance, late potentials, heart rate variability, sympathetic innervation parameters, nuclear studies like SPECT, MIBG methods have been used for risk prediction. There are no very clear specific guidelines, but that needs to be formed. And because as individual parameter, none of them has a very strong power to differentiate. You have to use multiple parameters, and despite that, the final results are conflicting and not very encouraging, because dilated cardiomyopathy is a very heterogeneous group of disorders. For certain types of dilated cardiomyopathy, the risk differentiation is good. For others, it is not. How do you use genetics and imaging? Well, genetic testing in DCM is reasonably rewarding, and 2022 European Society guidelines recommends that we do a genetic testing for patients with dilated cardiomyopathy, particularly in patients who are young and patients who have a conduction delay or patients who have a family history of cardiomyopathy or sudden cardiac death. That enables family screening and genotype specific follow-up and genotype type specific risk stratification can be done. There are many gene variants which are associated uh, and even in patients above the ejection fraction of 35%, which classically are not very high risk, but among them, if you have certain genetic variants, then those would fall into high risk subgroup and they can be taken under the umbrella of primary prevention. And again, in the imaging, if this genetic abnormality are associated with certain type of structural problems, like on MRI, you find late gadolinium enhancements, then again your risk prediction becomes more precise. So almost 40% of the patients with dilated cardiomyopathy have variety of fibrotic patches in their myocardium, and it was found that if you take these parameters into consideration, then even in subgroup of patients with ejection fraction more than 35%, you can predict the sudden cardiac death. Hypertrophic cardiomyopathy is a totally a different animal. Almost 1 in 500 of the general population have hypertrophic cardiomyopathy. Overall sudden cardiac death risk in HCM is low, like 1% per year. But it can be a very devastating. And a 5-year SCD risk stratification score has been developed. There are many parameters. If the patient is having that that person has a higher risk, and that would qualify for ICD therapy, like the patient's age, left ventricular wall thickness, left atrial size, left ventricular outflow tract obstruction, presence of non-sustained ventricular tachycardia, and history of unexplained syncope or family history of sudden cardiac death. When you combine together, you can differentiate patients into low risk, like less than 4%, to high risk more than 6%. And high risk patients would qualify for the cost and potential side effect of ICD therapy. But apart from these 7 parameters, there are many more parameters which could be predictive, which need to be included, and we need to find out the calculators using this. Is LV ejection fraction less than 50%, aneurysmal left ventricular apex, late gadolinium enhancement more than 15%, meaning thereby more fibrosis, and failure to increase systolic blood pressure by at least 20 during peak exercise, or even a fall of systolic blood pressure. So uh, these are the parameters which you are looking for when evaluating or risk stratifying patients with dilated with hypertrophic cardiomyopathy. Now, what about other types of cardiomyopathy? Like, for example, arrhythmogenic right ventricular dysplasia. There is a fibropathy replacement of the cardiac muscle in RV and sometimes in LV. Incidence is the prevalence is from 1 in 1,000 to 1 in 5,000, and it is primarily because of the desmosomal genes which cause it. ICD is recommended for majority of such patients because they are at a very high risk of sudden cardiac death, and exercise has a strong prediction, strong impact on disease progression. So you don't allow those patients to take sports as their kind of main hobby or main lifestyle. Mitral prolapse otherwise is a very innocuous condition found in almost 10% of the population, but some of them have an arrhythmic mitral valve prolapse, and they have a higher possibility of sudden cardiac death. So any patient with mitral prolapse who has a history of syncope, or on Holter you find non-sustained ventricular tachycardia, mitral annular disjunction, cardiac fibrosis on CMR LG evaluation, particularly inferior wall, lateral wall, and on papillary muscles, ejection fraction drops, T inversion alternans are there, ECG abnormalities are there, then you know that those group of patients are at a higher risk of sudden cardiac death. And now coming to the molecular mechanisms, channelopathies. We know that the myocardium, the electrical system works on the electrolyte channels like sodium, potassium, calcium, magnesium channels on the cell membrane. And variation, genetic variation in those channels alters the electrical stability of the myocardium, and obviously it can lead to ventricular tachycardia, fibrillation, sudden cardiac death. Brugada syndrome is one such common situation where risk assessment is very important in patients who had a syncope. You need to evaluate them thoroughly. You can do a programmed electrical stimulation or an electrophysiology study to find out their risk. And there are many other electric ECG patterns, etc., which would specify that this group of patients are at a higher risk and take them for ICD implantation. Congenital long QT syndrome, again, you can get various channelopathies. You can pick them up on genetic analysis. Untreated asymptomatic long QT syndrome patients have an annual sudden cardiac death of 0.5%. But those with an history of syncope, the risk now of a second cardiac arrest goes up to 5%, and those group of patients would qualify for preventive therapies. The electrocardiographic genetic parameters all can be combined together, and QTC, etc., can be taken into account. Now, not always everything can be predicted beforehand. Some patients would die. Take an opportunity there to learn from autopsy what was the mechanism of the sudden cardiac death. If you don't have any gross structural abnormality like coronary artery disease, etc., look for deeper and deeper into molecular mechanism, genetic analysis, etc. The hospital forensic setting is really required. Apart from standard autopsy, you might need a multidisciplinary conference with the cardiologist to find out what was the history of that patient, what was the family history of that patient, come to a conclusion, and whether it is an inheritable genetic abnormality. In that case, cascade screening of the first, second, and third degree family members can pick up the patients who are predisposed to sudden cardiac death. And autopsy negative patients with negative toxicology identifies a lot of channelopathy kind of patients, and where genetic analysis is going to be helpful. Combined postmortem testing, family investigation of first degree relatives can get a diagnostic yield of almost 40%. So selected subgroup of autopsies, the high risk patients, in their relatives, 40% of the people are likely to be high risk, and you can pick them up and prevent them. Now, we have understood a lot of developments, but still we are not perfect. And the long-term prediction of sudden cardiac death is not possible. So if you can't do a long-term prediction, what do? You do short-term investment, you do day trading. So that is the concept of near-term prevention. That's a new approach for preventing sudden cardiac death. See, all strategies that reduce sudden cardiac burden death have been trying well ahead of time. But the long-term prevention may not be possible. And it has been found that sudden cardiac death is actually preceded by some symptoms. They might be subtle symptoms, but they are. And if you can focus on those group of patients when they have some subtle symptoms or a warning signs, evaluate them, then possibly a large number of sudden cardiac deaths can be prevented. The problem is those symptoms are not specific. The kind of chest pains or breathlessness or mild dizziness can be caused by many other diseases other than cardiac. So to improve specificity, a multi-pronged approach beyond symptoms and clinical features might be needed. There are models which are being predicted based on ECG, Holter monitoring, etc. And they form a lot of promise. But the real promise comes from technology, like wearable devices. Wearable devices, your smart watches can pick up the data on oxygen saturation, heart rate, and even they can analyze the ECG. Combine that data or analyze that data with AI-based or machine learning, and you have a warning. Apple watches are already giving you a warning about abnormal heart rhythm. So it can predict atrial fibrillation, and there are a lot of trials that Apple Watch based detection of atrial fibrillation and what could be the preventive strategies for stroke in atrial fibrillation. The similar kind of strategies can come for ventricular tachycardia once that technique becomes more refined, once the Apple and Fitbit becomes more confident about their ECGs. Currently, they say that, okay, we have recorded ECG, but we are not responsible. Talk to your doctor. But when the technology improves, so somebody whose heart rate becomes very fast and oxygen saturation drops and his activity becomes low, you know that that guy is in a problem. So this models can be refined together. Near-term prediction can be there, and patients who has premonition kind of symptoms, you can pick up those patients and focus your sudden cardiac death preventing therapies on them. And one of the last slides, friends, few trivias. Deep vein thrombosis and pulmonary embolism is not unheard of in people who have long flights, and it has been found that people who sit on the window as compared to aisle, they have a little higher risk. That's the power of risk prediction, because the aisle guy is not going to get up very frequently because he has to disturb other people, and he becomes more sedentary and he becomes a higher risk. Sudden cardiac death among COVID and COVID vaccination is a hot topic of discussion. We do not have a final answer. The patients who are being treated with variety of anti-cancer drugs and therapies and radiation, they are at a higher risk of sudden cardiac death. And not only during therapy, but even after therapy, the risks are high. Like for example, Barton tyrosine kinase inhibitors have a higher risk of atrial fibrillation and ventricular tachycardia. First generation had 20% incidence. The second generation has less than 5% incidence, but still it is on higher side. Among the sports people, sudden cardiac death is not unheard of. The common mechanisms are hypertrophic cardiomyopathy, abnormal course of coronary when coronary, instead of going from the front of heart, goes between the aorta and pulmonary artery. So at the height of peak performance, aorta and pulmonary artery both dilate to accommodate very high cardiac output, and it will compress the coronary artery, and patient will get a myocardial infarction or a cardiac death, and some types of channelopathies. It has been recommended that competitive sports or high-end sports people should have at least one checkup before they embark on their lifetime journey. So friends, that brings me to the last slide. Despite advances in the field of predicting sudden cardiac death, there are very significant challenges in risk stratification. They must be overcome before a meaningful impact on SCD can be realized. Thank you very much, and namaste from Dr. Mahesh Shah from Bharat, that is India. Thank you.
Thank you, Dr. Mahesh Shah. It was a wonderful presentation, and I think a lot of inside information which everybody should know. I think we have discussed on this platform. I want to highlight about CPR program, which you mentioned initially. I think it's a life-saving program.
Yeah.
And I think everybody on this planet should know about CPR. We have seen incidents where a lot of people have saved life. So it is basically where you can save somebody's life even after death. And as a Heart Care Foundation of India, we have done a lot of training. We have treated most of the ground staff level because they are the people who can reach you faster. And I was reading some news over here recently. If you go, that there are a lot of, BACS force, there's a lot of, bus conductors, even the people who are delivering the food, they have recently saved life even after somebody has, fainted or somebody's died over there. And because they were present and they know what is the importance of CPR, they were able to save somebody's life. If you do not know what is CPR, if you cannot perform and you're waiting for an ambulance, it is already late, because the first 10 minutes is very important for the brain. So I would like to invite everyone for question answers if we have any. I know the session was conducted very well. Dr. Angelica, Dr. Akhtar.
Morning, Dr. Angelique here. Dr. Shah, it was really very an eye-opening again, and it's actually stuff that we're supposed to know, but to get it all together again, it just stir your memory again, what to do. However, one of the big problems at the primary healthcare level is how to identify and risk strategy your patients there. So in our surgery, we've got a sort of a program that we run, not sort of, we do that on our, from the age of 45, we start to make sure that we do the lipids and the cholesterol, the glucose. You try to look at the family history. Is there a history of previous sudden death or cardiovascular incidents in the family, cancer risks, or all of that? So you try to risk stratify them, and then try to do preventative medicine. That's about the best that we can do. I must say we don't have a very high incidence in our surgery because of some of these preventative measurements. But we also try to do stress ECGs on our high-risk patients. What we have picked up is that, I just want to refresh our memories again, that especially around females, if you are around about the age of 55 and above, we see a lot of females coming in complaining of arrhythmias, and it becomes difficult. We do on any with palpitations. Actually, that's the word that I will use. We try to do as much as possible 24-hour Holter ECGs, because we have seen that you don't always pick that up on a ECG or a stress ECG if you want to do it without any symptoms. It is much more common under our female patients, and interesting enough, we do see a higher risk of fibrillation or ventricular arrhythmia with these ladies. So my plea would be also to this group: don't just say it is your palpitations might be because you're going into menopause or something like that. Just double check on those patients, because they are at higher risk. Thank you.
Thank you. That's a very nice comment. Any other questions?
We should have a CPR session online, and I will try to make it happen. I think that's a wonderful suggestion, and
there is a very nice CPR cube available. It's a small, around 6 inch height, small square cube, and you compress that cube, and that has got an electronic circuitry. It gives you your performance in 3 parameters: the rate, the depth of compression, and the recoil. Because after compressing, you have to let the heart fill up, you have to recoil. So these 3 parameters it will evaluate, and if all 3 side lights are green, you are doing everything perfect. And it can be synced with your mobile, and it will give you the score. So that gives you a more perfect type of CPR training. And of course, there are many mannequins also available. So, but still, at least it is good to know how to do it. Online, it may not be possible to actually train them, but that would be a first step. They know everything, and then if CPR cubes are available, they can be given training offline in physical mode.
I have a question over here. It says, Dr. Vikram, it says, does raised APOA have any correlation with sudden cardiac death?
Well, Dr. Vikram, if you are talking about ApoB, ApoA, ApoB is the bad one, and it is associated with a higher incidence of atherosclerosis and consequently coronary artery disease and sudden cardiac death. ApoA is mainly associated with HDL and reverse cholesterol transport, and it is protective. So raised ApoA up to certain limit is not bad. Like if your HDL is below 40, your risk is high. So ApoA is below those levels, it is the risk is high. But when HDL goes from 40 to 80, your risk progressively diminishes. Above 80, again, there was a small publication recently that even when good cholesterol is too high, it is bad. So they say that in life that anything excess is harmful, so that is harmful. Now, if your question was LP little a, that is a apolipoprotein LP little a variety that has a structural similarity to fibrinogen, and it is an ApoB containing lipoprotein particle. So in that group of patients, the risk is very high. And LP little a, so far we didn't have. It is purely genetically determined. It is not affected by lifestyle. It is not affected by majority of lipid lowering drugs. But of late, we have a lot of research on that, and LP little a at least should be checked once in everybody's lifetime. And if you check it once, you don't need to check it again. As of today, because we don't have therapies, and you focus them on other primary prevention therapies like diet, exercise, LDL reduction, etc. So LP little a, very important, very strong marker, not only of atherosclerosis, but thrombosis, because it resembles LDL and it resembles fibrinogen. So it activates platelets and causes thrombosis.
So, Dr. Mahesh Shah, I have some questions on Facebook where they're very generalized question from the. Okay, Dr. Vikram, you want to ask another question? You have to unmute yourself.
Good morning, sir.
Good morning, Vikram. How are you?
Morning, sir. So you answered my question. I was referring to the little ApoA. Now, there are a couple of patients who are coming in with reports who say the values are around, 40, 45. Because of this sudden cardiac death scare that has suddenly come up. So in such cases, because it is genetically determined, what kind of advice do you give such patients? And if their values are around 40, 45, what are those people supposed to do? Are they supposed to undertake regular walking exercises, these things? Or, I mean, what does one as a treating doctor give advice to such patients?
All right. LP little a, the normal range is something like 15-20, but up to 50, the risk is not great. So you don't start embarking on ApoA reducing therapy. So far as lifestyle is concerned, in terms of walking more than 10,000 steps a day and being active whole day and climbing a lot of stairs, it is required for everyone. Everyone needs it, whether you are at a high risk or not. Now, if this patient, what I would do is put all his data into the classical risk scores which are available, either ASCVD risk score available online free of charge, or Q risk free score. You just search online, you'll get that. You just put in simple basic data: patient's age, gender, height, weight, diabetic status, hypertensive status, LDL levels, LDL HDL ratio, their ethnicity, like whether they are black, white, Hispanic, etc. And it will give you 10-year risk prediction, and there is also Q risk lifetime risk prediction. So somebody who is below the age of 40, you can put his data into Q risk lifetime. And those risk calculators will give you that what is patient's risk over 10 years or over lifetime, depending upon the calculator used, and comparative risk of an average person, and plus it will give you some basic advice what is to be done. So if ASCVD risk is less than 5%, just routine lifestyle which is required for everyone. If risk is between 5 to 7.5%, little more aggressive lifestyle and discussion about statin. If the patient is willing to take statin, they can be given. Above 7.5, moderate intensity statin. About 10 or 15, high intensity statin therapy, and evaluation for coronary score, etc. is something what we do. LP little a and other things. Now in this risk calculator, 5 or 7 parameters are considered, but there are risk modifiers. They are the parameters which are not taken into account into this risk calculators. When the risk calculators were done, we had the data about only those 5-7 parameters. Then we have a marker of inflammation like HSCRP, LP little a. So there are many such markers which are risk modifiers. So more the risk modifier calculator markers you have, and if somebody falls onto the borderline, say somebody who has a 5.9% risk and 2-3 risk modifiers, I would put him into a higher category, and I'll have a lower threshold of putting him on statin or dyslipidemia therapy. Or say even hypertension, if somebody comes with a borderline blood pressure, you don't need to, if the patient is falling into very low risk group, you might continue with lifestyle modification. But somebody who has a 132 systolic pressure consistently and he is falling into high risk category, I would treat his hypertension more aggressively. So these
Thank
are
you, thank
few
you.
of the things which we have to put a calculations in your mind. Every patient is different. Patient in front of you doesn't fit into every guideline, every trial, or every publication.
So up to a value of 50, you feel is okay. You don't need to
Up
do
to
much.
value of 50, you don't need to
Because
really.
some laboratories are showing a value as of 40 also at a high risk. That's why
Yeah.
is
No, up to 50, the current guidelines say that you don't need to be scared, and once you have measured, you don't need to do it again. Unfortunately, there are two different techniques which are used. One is in millimole and another is in milligram. What we are talking about common in India, what we measure is milligram per deciliter. So since we have attendees from different parts of the world, you have to find out whether which method you are using, which unit you are using, and what are the normal, because millimole, it is 2.5 times this thing. So if it's reported in millimole, it's 125, which would be the cutoff value.
thank you, sir. Thank you, sir.
Pleasure.
Question which have been raised, and there are a couple of questions. One is, considering what is the lifestyle, considering the hereditary, there is a lot of young hypertension kids, and which the world is seeing right now. So, do you have any advice for them? Like, the problem is a lot of people have a young hypertension, and they're not aware because they are not into going and getting a regular checkup done. So they just see a headache, they take a medicine, they just move on and keeps going on all that stuff, and then it can actually cause a damage to the heart. So what all people need to take care of it? How is lifestyle being related to the young hypertension, and is hypertension being reversible?
Yes, hypertension in early stages, particularly stage 1 at early age, can be reversible because there are many reversible factors like lack of exercise. Salt intake is one of the most important. Mental stress, disturbed diurnal cycles like sleep and wake cycles. There are many BPOs which are work in India. They work whole night and daytime. They are not working. Lot of unhealthy food choices like packaged food, hotel food. It's always high in salt. So these are the things which you focus on in a young hypertensive patient. Right from the age of 20, you should start screening people for blood pressure. There is a Public Health Foundation of India which is running a campaign of May Measurement Month, wherein you measure as many number of patients' blood pressure, patients, relatives, attendants, whoever comes to your clinic, you do it. There are many companies, I think pharma companies like Aris has given put in stalls at airports, etc. School health screening or colleges can be another focus where, if you start measuring, a large number of them will be detected. Once detected, at least some of them will be starting their lifestyle, etc. You need not be very aggressive at a very young age of 20 to embark on pharmacotherapy right from start, but healthy choices about lifestyle, particularly food, is really important in those group of patients. And periodic screening after the age of 20, once it is done, every 3 to 5 years, it is recommended that an opportunistic screening. When a patient comes to you, all young relatives who come to you, you ask your secretary to check their BP and tell them. That's what we can take those opportunities to detect hypertension, one of the major killer in cardiovascular spectrum.
So in fact, I think I remember we had given a suggestion that if you go to a Western country like US and Canada, a lot of chemists and a lot of malls, they have a BP screening machine.
True.
Where you can just walk and you can just sit over there, put your arm there, and you can take a BP, and it's free of cost available. So it just not only adds interest in a lot of people who are walking around, because I think the problem is people to go to a hospital, go to a place where their condition, and exposure of that. So that is the reason a lot of people don't do that. But if this kind of a system comes in where all the malls and everywhere, people, they have a screening machine on the just at the corner, I think that will really help people to understand how to, what is going wrong in the body. A basic system to check in your body.
I think that's a very important concept. Like Aris, as I told you, they are doing it on airports. NGOs like you can tie up with corporates, and corporates have a lot of social responsibility, budgets, and tendencies. We can combine those things together and put this kind of machine. Not only this machine, but there can be, sugar checking machine. Renal blood sugar can be checked. or CPR training, and you can have a kiosk kind of thing wherein multiple CV prevention modalities are being done, and you can have some displays there for the health education of people. Smartly designed, this kind of cabins could be really helpful, and defibrillator should be made mandatory. In my opinion, if I was health minister, it should be mandatory in all gyms, because gyms are the place where people embark on sudden increased activity, and when you start a new exercise program, there is a slightly increased incidence of sudden cardiac death. So all gym must have a defibrillator machine. All gym staff must be CPR trained, and periodically they should be recertified. It should be just not simple training, but they should be a certified training and periodic certified training. It should also be available at all police stations, all schools, all malls, all cinema halls. So, or any place where large number of people gather, like industrial expos are there, any kind of industrial expos, healthcare expos, or IT expos, or whichever expos there are. Large number of people getting accumulated. You have a crowd control rules and you have a traffic control rules. You also should have this kind of devices mandated by law. And then probably, the awareness will spread and the recovery rate from sudden cardiac death would come down.
Absolutely. So in fact, we were blessed to do that. We did train all the the police force, the police stations. We also did training for a lot of traffic police, who are on the roads. We did training for a lot of judges and lawyers, and we were in terms of doing training for the ground level staff, where they can like people who deliver, like today, if you can order a pizza, it will deliver in 30 minutes, but if you order an ambulance, it will not deliver in 30 minutes. It will not come in 30 minutes. So I think, considering that fact, like if something happens in your body and you need a help, I think 10 minutes grocery delivery is something which people should target, and they should come over here and even do a CPR training. Instead of ordering a noodles for 10 minutes, people should say, okay, need a help for 10 minutes, and they should be there in your 10 minutes.
Yeah, there was a Seattle Heart Watch study wherein in one particular area, every 5 minutes, 10 minutes, there is a certified CPR guy is available. And once he raises a signal and starts CPR, the whole subsequent machinery of ambulance, etc., come in US very fast, 5 minutes, 7 minutes, 10 minutes. They take life very seriously. Even if you are an illegal immigrant, they take your life very seriously, and they are going to treat you if you land up with emergency like heart attack or sudden cardiac death.
So that is a problem over there.
Bystander initiated CPR saved, I don't remember the exact figures, but it saved a hell lot more lives out of the
absolutely
observed CPRs.
Absolutely. The problem with the Indian ambulance is that there's a lot of traffic and there's no discipline in the road. So if the ambulance is beeping, people try to chase the ambulance to go faster rather than getting away. In US or Canada, there are shoulders available. So you can't a regular person cannot drive on shoulder, and shoulder is only for emergency, for ambulance and everything.
Yeah.
So again, I agree with you, but yeah, bystander is a good concept of CPR, where every person, especially the delivery guy, should be bystander, and you can just go to an app and say, okay, I need a bystander, or I need a help, emergency help, and you also should know. It's not that you are reliable on somebody. You can. It's very easy. It's like a very easy concept, and you don't need to be a doctor to do that. Okay. Do we have any other questions? I think we are over time now. I think I would apologize, Dr. Mahesh. We are over time. I think we should end this session now with this last note, thanking you. And if you have any take-home message, please do give to the audience who are not doctors. And we post that, we'll close the session. And I thank you for enlightening us for the immense knowledge about this sudden cardiac arrest.
I think it was a real pleasure talking to a large number of people across the globe. Sudden cardiac death is a very serious entity, needs to be taken very seriously. There could be early subtle signs wherein people can be picked up and sent for evaluation at a higher center. And in different disease characteristics, there are certain markers try to look for, and above all, learn CPR. Everybody around you, if you know CPR, everybody around you, you try to propagate that health life-saving skill as much as possible. That's the message I would like to give.
With this note, we thank you, Dr. Mahesh Shah, to join us for this session. We will see you again in coming weeks. And I think I would say also Happy New Year to everyone, in case we don't meet in this year again. So thank you for joining in, and Merry Christmas as well.
Thank you very much.
Thank you.